Okay, well, uh, hello everyone. Good afternoon. Happy Friday. My name is Jennifer Ramirez, and I am the Strategic Operations Manager for the Women's Fund. And we are lucky enough to have this amazing presentation once again this year, presented by Dr. Fischer and Dr. Mott, that are going to be talking to us about fibroids and the importance of it. It is July, it is Fibroids Awareness Month. And so, what better month to have this presentation than now? Just a brief intro. We are the Women's Fund, and we're a nonprofit here in Houston, and uh, we provide Houston area women and girls with the tools they need to be advocates for their own health. And so we do this through health education. So we are very happy when we were very excited when the Fibroid Institute of Houston reached out to us in collaboration with Dr. Mott to do this presentation once again. So with that being said, I won't go through any more than that to allow for them to talk to us about this amazing topic. But I do want to give a brief introduction for both Dr. Fischer and Dr. Mott. So just a little bit about them, starting with Dr. Wanda Mott. So Dr. Mott is a board certified obstetrician gynecologist, medical director of women's specialist of Houston at Texas Children's Hospital, and an assistant clinical professor at Baylor College of Medicine. She has more than 20 years of experience, and she is nationally recognized for her expertise in women's health, minimal invasive gynecology surgery, and patient education. She is a frequent speaker and recipient of many numerous honors, including multiple Texas Monthly Top Doc and Super Doc awards. And Dr. Maud is a passionate advocate and a big advocate for advancing women's health and reducing health disparities. So amazing. Thank you for the wonderful work that you do, Dr. Mott. And Dr. Robert Fischer. So Dr. Fischer is an interventional radiologist with more than 20 years of experience treating uterine fibroids through minimally invasive procedures, trained at Baylor College of Medicine, the University of Washington, and MD Anderson Cancer Institute. He has performed over 3,500 uterine fibroid embolizations and was among the first physicians to introduce the procedure into Houston. So thank you for that. And he is the founder of Fibroid Institute Houston, the city's first dedicated outpatient UFE treatment center where he provides personalized and patient-centered care. So what better to explain to us about the importance of fibroids than these two amazing, wonderful doctors? So with that being said, let's go ahead and get into it. So starting off with Dr. Mott.
Well, gee, thanks, Jennifer. Thanks for the introduction. And John, it's very good to see you. I'm really glad to be able to participate in this Fibroid Awareness Month because certainly it is something that we see tremendously in our community. And we want to make sure that we're getting people aware of the things that they can do. Jennifer, if we can go to the first slide, please. All right, so fibroids are extra pieces of muscle on the uterus. This picture here shows you the little whitened area there with the instrument. This is done through laparoscopy. You can see it looks like a little marble, and it's about 3 centimeters in its widest diameter. The rest of that pinker body there is the uterus, and you have the tube, okay, on that far left side is what you're seeing. So you can see that fibroids are part of the uterus. They are non-cancerous, they are benign, they are associated with lots of symptoms, and they can be associated with no symptoms. So ladies can have fibroids and have an incidental finding of them and not have any symptoms, but they can be numerous in the number that they are in the uterus, or they can be just an occasional one. They can come in clusters or they can come together. Next slide, please. Certainly, what causes fibroids? We really don't know. Okay, we know that they are dependent or certainly they're affected by estrogen and progesterone. They are very common in the reproductive years, but honestly, they're there on the uterus most of your life. So the majority, 40 to 80% of women will have these, and usually they appear as far as symptomatic usually between the age of 30 and 50. If you look at that small picture, and this is like a cross section of the uterus, if we look where the pointer or the pin is, there is a little calcified area, just like we saw in the other one, okay, in the muscle wall of the uterus. And that's what we're looking at, the wall of the uterus itself, the surface, and it goes into the muscle. That pinkish area in the center is where the menstrual flow comes from. So we're looking at fibroids in the cavity or on the surface, and they can change the things that as far as symptoms associated with that. Certainly you can imagine having a mass inside the cavity, which is where, if you were achieving pregnancy, where that would be. Certainly, we do find that millions of women have fibroids, but it seems that there are certain factors that are very common, and that Black women seem to have much larger fibroids and more often, okay, than women of other ethnic groups. But they do appear in all ethnic groups. Next slide, please. Certainly, when we talk about symptoms, when you talk about something being larger than it should be, then you're going to have a feeling of bloating or fullness in the lower abdomen. And certainly certainly the normal uterus is the size of a Bartlett pear. So as it grows in the pelvis, there will be a sense of heaviness. And certainly because fibroids can be in the lining of the uterus, where the menstrual flow comes from, there can be excessive bleeding in the wall where the muscle is contracting. There can be tense, very intense, painful, okay, menstrual cycles. There will also, and can be, because the bladder, the uterus, and the rectum sit right up against each other, sort of like sheets of paper. If there were 3 sheets of paper here and they are actually expanding spaces based on what is in them. When the bladder is full, it expands. So there's fluid there, but then it goes back down and it's a single sheet. Where the uterus sits is in the middle. And certainly if it expands associated with the fibroids, then it pushes on the bladder and pushes on the rectum. So it can produce a tremendous amount of pressure and discomfort. Next slide, please. Other symptoms associated with this may be back pain, okay, or painful intercourse, constipation. You can imagine getting larger masses, the size of marbles. They could be the size of peanuts. They can be the size of a softball. They can grow, and we've had ladies to have fibroids up against the liver, and that's up in the upper abdomen. So they can be multiple sizes, taking many years to develop to that point. But they could cause compression, okay, on the bowel, as well as increasing pressure on the bladder as well. And also, there can be this enlargement in the abdomen makes you feel or look almost pregnant. When the fibroids are in the cavity of the uterus, they can come through the lining of the uterus. Remember, this is where we have the menstrual flow and the bleeding. But sometimes the fibroids that are in the cavity can come through the cervix or the opening of the uterus, and that opens the uterus itself. And that results in what is called a watery discharge. It's a running. It's a discharge where you have to change pads regularly, okay, because of this. It's not bloody, it's just watery. And that means that a fibroid is coming through. Next slide, please. Thank you. So you want to know what makes me at risk for fibroids? Well, the biggest thing is your family history. You will know that other women in your family, as long as you guys talk, have really bad periods. They may not tell you they have fibroids, but their periods have always been horrible. They bleed for long periods of time. They have tremendous discomfort. They have to limit their activities. And certainly this in itself increases the possibility, not always, of having fibroids. early onset of menstruation and late onset of menopause means that there is an increase of exposure. Remember, we talked about those hormones of estrogen and progestin. It is that the fibroids are very sensitive to, and they will grow, even though they are inherited or genetic or come through oftentimes through a family history. Certainly, obesity is associated with an increase in fibroids because with obesity in the fatty tissue, there is a chemical created that is very similar to estrogen. So you normally have your estrogen from the ovaries, and you have this chemical, which is called androstenedione, never mind what it's called, just Andy, okay, that works. That chemical added with the estrogen means you have twice as much, okay, in the system, depending on your weight. So that would cause the fibroids to be driven to grow more. And also, there's been some association with low vitamin D associated with the risk for fibroids. Next slide, please. So we're learning all about them. So what are the complications? Well, if you have a big mass and you have fat fibroids coming through the lining, certainly the biggest complication that people come into for fibroids is excessive bleeding. They have severe anemia, and they over time, people get really used to having really heavy periods. But the real level of blood loss associated with a menstrual period is 1/4 cup of blood for the whole cycle. And many women experience large amounts of blood loss with their cycle. They change a pad or a tampon an hour, sometimes two an hour. And certainly that is considered excessive bleeding. It will result in severe anemia and can compromise one's health. Certainly, because of the pain that is associated with these, many times it's unmanageable. Ladies will take Tylenol, Advil, BC powder, all types of things to try to get it to go away. They'll use a heating pad. People will get into the bathtub for warm baths. All of that are things that we can do for it, but honestly, when they get excessive, it doesn't decrease the amount of pain. Certainly, the swelling in the abdomen is associated with the increase in size. You can imagine that if you have masses in the cavity that are interfering and causing excessive bleeding, how that might interfere with a pregnancy. Pregnancy takes place inside of the cavity of the uterus. So if you have mass that's estrogen dependent, or actually it accelerates its growth associated with estrogen, and then you have a fetus, there's 1,000 times more estrogen made in the placenta than there is in the ovaries at the time of cycles. So you can imagine the competition between the fibroid and the pregnancy. And it can oftentimes result in difficulties achieving pregnancy and multiple problems during pregnancy itself, and also maintaining pregnancy. Next slide, please. All right, so we talked about fibroids. How do you find out you have them? You may not even know that you have them, and you may not even have any problems with your cycle. Certainly, having very heavy cycles, painful cycles, anything along those lines, abdominal masses, should make you go in to your provider for evaluation. Once the exam is done, then there are several studies that can be done to document exactly where this is coming from. One of the easiest and least expensive is an ultrasound. A pelvic and abdominal ultrasound done vaginally as well as abdominally will allow you to visualize the uterus, the tubes, the ovaries, the bladder, the bowel, and see where there are masses and if there are any masses. You can become more specific in your evaluation of the fibroids with a magnetic resonance imaging test, which will give us specifically how many fibroids are in the uterus, what their dimensions are, what normal muscle is available to the uterus, and also what is happening with the ovaries and the bladder and the rectum, how they are being affected. Because the other thing I didn't mention is fibroids are parasitic masses. Remember, the uterus starts out being the size of a Bartlett pear. So if it's expanded to something that's up under your navel, it's got to get blood supply from somewhere. So it's a parasitic mass. It will begin to attach to other organs that have greater blood supply. Another mechanism for visualizing fibroids, especially the ones in the cavity, is a hysteroscopy. It's taking a telescope instrument, sort of about the size of a pen, the width of a pen, and going into the lining of the uterus through the vagina, in through the cervix to look at the lining. That way, those fibroids that are there can be visualized. Any fibroids in the cervix can be visualized. An x-ray of the lining of the uterus and tubes is called a histosalpingogram. It's basically fluid sent through the same place, through the vagina, into the uterus, and out the tubes, so you can outline the masses, if there are any masses in the cavity. And certainly laparoscopy, which is the same kind of telescope, but going through the navel, visualizing the uterus, tubes, ovaries, the entire pelvis, and it can allow you to visualize the upper abdomen as well. Next slide, please. So what are treatments? We talked about treatments. How are the fibroids treated? They are treated with pain medicine. People don't even know they have them. So they're taking over-the-counter medicine. They know that they feel badly with their cycles, so they take over-the-counter iron supplements. Certainly many times when they go in to see their doctors, because the bleedings are heavy and the fibroids may not be palpable at the time of the visit. Oftentimes, ladies are placed on birth control pills. Certainly, there are medications. There is a drug called tranexamic acid or Lysteta, which is available and will decrease the heaviness of bleeding at the time of the cycle. And this can be used 3 times a day during the heaviest times of bleeding and will drop the flow. Certainly, these are things that can be discussed with your provider. There are what are called GRNH agonists, which are, and maybe you've heard of these, or maybe someone in your family has been on them. This is Depo-Lupron. It's an injection that is given up to monthly, or it can be every 3 months to decrease the size of fibroids. Certainly, this is very effective during the time that you're taking the medicine, but there are pros and cons that you need to discuss with your provider before you use them. We already talked about oral therapies, and certainly there are many things that people use, home remedies, all kinds of things, okay, to decrease the amount. And there's alternative medicine as well. Certainly, when we talk about procedures, and that's what we want to discuss, because you want to make a decision as to whether or not this bleeding is such or the masses are such that you really need to do something about them, or they're going to compromise your fertility, or they're already compromising your health. Next slide, please. So fibroids, there's lots of information about them. Many times when women find out that they have them, they automatically think that they need to come out. They need to have surgery. That's not true. Okay. It depends on how many fibroids you have. It depends on where they sit, on the size of your uterus, on what type of symptoms they're giving you. And when you once you have your ultrasound and evaluation, you should sit with your provider, talk about the positioning of the fibroids, what symptoms come with those positions, where I am now, and what is my plan? What is my plan, my life plan? Okay. Or do I have very large masses where I need to do something? Or is this a very small uterus? It's just an incidental finding, and I need to be aware. I need to let other people in my family, if I have sisters or nieces, I need to let them know that this is something that they may have to deal with. It may affect their pregnancy potential. It may affect their fertility. It helps people to plan. And certainly that's what you want to be able to do. Next slide, please. So when we look at surgery, fibroid surgery is called a myomectomy, and it should be the last thing that we come to. Okay, because there's lots of things that are available to help you to decrease bleeding, pain, discomfort, the size of the masses, all of these things before we come to surgery. Surgery for fibroids can be done through the hysteroscope. Remember, I talked to you about the little telescope-like instrument that goes in through the cervix to visualize the lining of the uterus. Certainly, we can also remove masses, okay, through that hysteroscope, because you have fibroids that are in the cavity that may be compromising the pregnancy potential. You can also look through the laparoscope, the telescope I talked to you about, that can be placed through the navel. We can do that robotically, or certainly we can do through what is called a straight stick, which is directly through the laparoscope to visualize the fibroids and to remove them. They can be removed, and the uterus can be repaired at that time. They have to be a certain size, and the position of the fibroids is very important. And certainly your provider will talk to you about that. The last form of myomectomy is called a laparotomy. That is when the fibroids are in such a space that they cannot be removed laparoscopically, or they are such size that they cannot be removed laparoscopically. Now, the thing you have to remember about myomectomy is the reason you're doing this is most of the time is because you want to preserve fertility. You want to make sure that you're able to close the uterus in multiple layers and keep it, okay, from when it expands with pregnancy, not opening, okay, in those places where you have removed tissue. So those are all discussions you have to have with your provider or your surgeon before you have those done. Next slide, please. Now, when we talk about fibroid surgery for removal, and we talked about myomectomy, the other possibility is hysterectomy. Sometimes when ladies, and remember we talked about the fibroids being there early in life, okay, and they will last through the menopause. Certainly in the perimenopause, oftentimes the fibroids will grow because the hormone level, the estrogen and progestin level varies. Your ovulation is not the same every month. Cycles are changing. Estrogen is higher, then lower, and it stimulates oftentimes the growth. And this may be their biological clock for growth before, especially if you talk to other ladies in your family that have had bleeding problems. They had their children, they had no problem, they had regular periods. Then when they got in their 40s, their periods went out to lunch. They had bleeding all the time. And certainly when they had their evaluation, they had fibroids and they had to have something done. So, you want to talk about hysterectomy. That means the removal of the uterus. It does not mean the removal of the ovaries at all. That's a different procedure. Certainly, before you come to something as aggressive as a hysterectomy, you might want to consider uterine fibroid embolization, which is a procedure that Dr. Fischer is going to give us lots of information on and works very well and has been very helpful to many. And there's also radio frequency ablation, and this is also available through your provider, and understanding the utilization of those and when they should be used, okay, is what is most important. And you have to seek that information based on your illness, where your fibroids are, what your life plan is to determine which way you need to go. All right, fantastic. I think that's the end of my slides. I'm going to stop now and let John go forward. I hope it helps.
Thank you very much, Wanda. That was fantastic. And thank you to the Women's Fund for this opportunity. It's a wonderful opportunity, especially this time of year in July, as has already been alluded to, is Fibroid Awareness Month. And so all of this is about education. It's about awareness, education, what's out there. Both Dr. Mott and I have been working together for many years, probably more than either of us is willing to admit to, in providing patients with the knowledge and empowering them with the knowledge that they need to make better, more informed decisions about their fibroid treatment options. And it's been an honor to do that. And I appreciate the opportunity to speak today more about the procedure that I do, which is called uterine fibroid embolization. I have a practice that's dedicated to the treatment of fibroids with this procedure. Dr. Mott very nicely summarized some of the other options available. And before I start into this, I just want to make it clear, no one procedure is best for every patient. The UFE procedures are a great procedure. The robotic surgeries are great procedures. The myomectomy, I mean, all of it is out there and it's available to help patients control their symptoms with fibroids, but it is not a one size fits all. And I think it's very important to understand that. And that's really why I spend so much time talking not only about UFE when I do consultations with patients, but also about all the other options as well. Because I want patients to know that, the good news is that there are more options available today than there ever have been. And as Dr. Mott said, I mean, some patients can get by with controlling their symptoms until menopause with no procedures. And if that's possible, that's ideal. just with medications or hormone therapies. There's better medications than we've ever had. So, we don't treat fibroids just because they're present. I like to tell patients all the time that, if they're not bothering you, we don't bother them. And fortunately, the majority of women with fibroids never know that they have them because they never have any symptoms. But when they do develop symptoms, it's important to research the different options. As Dr. Mott said, consult with your provider as to what the best option is for you and to educate yourself what else is out there. So I'm the medical director and founder of the Fibroid Institute Houston. I think we're the only dedicated UFE treatment center in town still. I've been doing this procedure for a very long time, and it's like I said, a wonderful option for many patients, but it's not for everybody. So with that, next slide, please. So a little bit of background about, I think you went, there you go. All right, a little bit of background, as Dr. Mott already alluded to, fibroids are just benign muscle tumors of the uterus. They're a major burden on our healthcare system. I mean, they're so common, up to 80% of all women will have them. Fortunately, most that have them never know that they have them because they never have any symptoms. But about 25% of women, about 1 in 4, do eventually develop symptoms, and it leads to an estimated $30 billion annually in treatments, complications, and lost productivity because of the severe symptoms they can cause. As I mentioned, up to 80% of all women disproportionately affects Black women and women of color. Hysterectomy is still the second most common surgery performed in the U.S. It's kind of the most commonly performed surgery for fibroid-related symptoms, but as I mentioned, there are multiple other options available today. The issue is that not all women are aware of all of their options, treatment options, and that's really what I try to stress is education and making patients aware of what else is out there. So up to 41% of women see at least 2 gynecologists and wait an average of 3.6 years for treatment. And, for many women, waiting is really the worst thing you can do because if you wait, the fibroids get bigger, the fewer treatment options you may have available, and the symptoms continue to get worse and can lead to not only a lot of disruption in your life, but also some serious health problems as well. Next slide, please. So uterine fibroid embolization was kind of a serendipitous discovery. It was first reported in France in 1995, where they were treating women with embolization prior to planned myomectomies, where they were surgically removing the fibroids. And the reason they were doing that was to try to reduce blood loss at the time of surgery. And the way that the system was set up, patients were scheduled for their UFE procedure and then scheduled for surgery about 3 months later. And a lot of the patients weren't showing up for their surgeries. And so when they would call the patients to say, hey, you've been waiting for this surgery for 3 months, how come you didn't show up? They're like, well, my symptoms are better. So that's how they stumbled across it, like so many other scientific discoveries in medicine and otherwise, kind of stumbled across UFE as a potential, primary treatment option for fibroids. The first case in the US was reported at UCLA in 1997. I did my first case here in Houston in 2001, and it wasn't until 2008 that the American College of Obstetrics and Gynecology came out with a statement in their practice bulletin that basically recommended UFE and said it had, consistent level A scientific evidence based on long and short-term outcomes, and it was a safe and effective option for many women suffering from fibroids. Next slide, please. UFE is also called UAE. You may refer to it either way, uterine fibroid embolization, uterine artery embolization. They're pretty much used interchangeably. Next slide, please. So like any procedure, the really foundation for good or successful clinical outcomes is patient selection. As I've already mentioned, this procedure and no procedure is best for every patient. But the good news is there are a lot of different options available out there now, more so than we've ever had. So the simplest are the hormone or drug therapies, as Dr. Mott alluded to already. She's nicely covered the potential surgical options, both the open surgery, the traditional surgery, and the minimally invasive surgery. Minimally invasive surgery, if it can be done, is really, ideal for many patients because it accomplishes the same goal as open surgery, but usually in half the recovery time or less. So patients get back to their lives quicker. There are some thermal ablation technologies, as Dr. Mott mentioned, the RF ablation like the Acessa, Sonata, endometrial ablation, and even an MR-guided focused ultrasound with Dr. Mott and I have both worked with in the past. And then there's the UFE or UAE procedure that I do. So next slide, please. So how do we decide what the best treatment option are or is for any given patient? Well, There are multiple things that we look at, but some of the most important are the number of fibroids in the uterus, the location of those fibroids, the size of the fibroids, and their blood supply. We also look at patient-centered factors like age of the patient, whether or not she still desires fertility, what, if any, other medical problems that she may have, and what, if any, prior fibroid treatments that she's had. And we take all this information together, along with some social considerations as well. There are just some patients that, because they're taking care of a loved one, a child with special needs, or a parent with special needs, they just can't afford to take off, 6 weeks for traditional open surgery. So we take all these things in consideration, and it's not a one size fits all. But many women end up having more than one good or reasonable option, and then that's where it becomes a very personal decision. And that's where the education is important, because the more knowledge a patient has about the different options, the better decision she can make for herself, regardless of what that is. Next slide, please. So Dr. Mott also talked about the different imaging modalities. Pelvic ultrasound is still by far the most common and the most readily available imaging modality for fibroids. It's a great screening tool for fibroids. Next slide, please. More recently, we've been using MRI, more and more to evaluate fibroids. It has some definitive advantages to ultrasound alone. It provides better tissue characterization. It is less user dependent, so less dependent on who's doing the scan, and more reproducible. It is not as readily available. It is a bit more expensive and time consuming than an ultrasound. So like everything in life, there are pros and cons to both. But pelvic MRI is a very important part of the workup for UFE because most importantly to us, it provides information about the blood flow to the fibroids. And that's really what we're doing with the fibroid embolization procedures, taking away the blood supply. So we need to know how much there is and ideally where it's coming from. Next slide, please. So as I just mentioned, not only does MRI provide much better information about the blood flow or really any information, but it can identify other things that ultrasound can't identify. So there's a condition known as uterine adenomyosis, which is very common. This is a bit of an oversimplification, but it's basically like an endometriosis of the muscular wall of the uterus, and it can cause heavy bleeding and other symptoms identical to fibroids, and we commonly see it with fibroids. It's a very difficult diagnosis to make with ultrasound, unless it's a relatively severe case. MRI is much more sensitive in detecting it, and it's important because it can change the treatment options or management of a patient. Many times with enlarged fibroid uteri, it can be very difficult, if not impossible, to see the ovaries on ultrasound as well. So if we want to rule out ovarian abnormalities or ovarian pathology prior to whatever treatment a patient's going to have, the MRI can be advantageous in that way as well. Next slide, please. So the UFE procedure that I do is an office-based procedure. It has evolved into that. I used to do all the procedures out of the hospital, but I now do them outpatient. It is minimally invasive. We do it through a tiny puncture hole into an artery, either the left wrist or the top of the right leg. We do either one. And it involves no incisions, no sutures. I don't even use a scalpel during the procedure, but everything is done with imaging, X-ray, and ultrasound guidance. It's done under a deep IV sedation. There's no general anesthetic or breathing tubes or breathing machines necessary. And what we do is we place a small little catheter about the size of the tip of a pin in diameter, but it's long. We place it inside the artery, and we use the X-ray camera over the top to guide or steer that tiny catheter or tube into the blood supply feeding the fibroids. Most of the time, that's from the uterine arteries, but it can come from other sources, rarely as well. But we place the tube into the uterine arteries, and then we inject these tiny little embolic particles. We use two different types. One is made of gelatin, the other one of foam. Both have been on the market for a long time in the US, over 25 years, and they're both FDA approved for this procedure and have been shown to be very safe. And we inject these little particles inside. The little particles get carried by the blood flow into the smaller and smaller branches of the arteries inside the fibroid or fibroids until eventually they reach a tiny blood vessel that is smaller than they are, and they get stuck. And so they're too big to go forward. They can't go forward and get back into your circulation, which is a very common question. And they can't go backwards because there's still blood flow coming in behind. So they get trapped in these tiny blood vessels within the fibroid or fibroids, and they block them all off. And that's how we shut down the blood supply to the fibroids. And that's really what embolization is, just a fancy medical term for cutting off the blood supply to something. So that's the whole premise of the procedure. is that we're cutting off the blood supply to the fibroids and causing the fibroids to shrink and die. The procedure is now covered by most all major health insurance companies as well, and it's becoming, more and more commonly utilized. Next slide, please. As I mentioned, we can do it through one of two accesses, either through the arm or through the wrist. We're doing most of the wrist simply because patients tend to find it more comfortable and allows patients to get up and move around more quickly after the procedure. The little picture at the bottom of the right of the screen there shows a little what we call a TR band, which is basically a pressure bracelet that we put on the wrist after the procedure to hold pressure on the tiny puncture hole. And then we slowly release the air, the pressure in the bracelet, and then we take the bracelet off before patients go home. Typically, the patients go home within an hour, hour and a half after the procedure. They have very few physical limitations other than how they feel. But the average complete recovery time after UFE procedure is about a week, 10 days, maybe something like that. And it's because there are some very common symptoms that occur after the procedure that we refer to collectively as the post-embolization syndrome. A very important part also, if any of you have heard anything about the UFE procedure, you've probably heard about how painful it can be after. So pain has always been the primary challenge is pain control. And the reason the procedure can cause significant pain, and most women describe it as moderate to severe menstrual cramping. The reason for that is what we call an ischemic pain. It's just the body's warning signal that we've cut off the blood supply to something. Same reason why patients with heart attacks get chest pain when the blood supply to the heart gets compromised. So when I was doing the procedure in the hospital, we used to admit everybody overnight. We put them on a pain pump. Many, not all, but many required significant doses of IV pain medication to help control that pain. But what we're doing now that allows us to control the pain really much better than we ever could by keeping patients in the hospital, but still send them home the same day, is what we call a hypogastric or pelvic nerve block. And this is done during the procedure. It just takes an extra 5 minutes or so. And what we do is we insert a small needle just underneath the belly button and into what we call the pelvic nerve plexus or area, and we inject a special combination of medications around the pelvic nerve that basically numbs the nerve and keeps it from sensing pain. And that's why we can send most of our patients home with either very mild or no pain after the procedure. And it usually works very well to help control the pain for several days. And that has made a huge difference in terms of patient comfort and overall recovery. Next slide, please. I've already touched basically on the embolic particles. These are little particles that we inject. There are two different types. One is called embosphere. It's a gelatin particle, a gelatinous particle. The other one is PVA or polyvinyl alcohol, which is the foam-like particle. They're both approved by the FDA for the procedure. They've been used for many, many years, have been shown to be not, only effective, but also very safe, and they're equally effective. Never seen, heard about, or read about any long-term effects of having these inside your fibroids or inside your body. Next slide, please. So as I alluded to, there are some symptoms that are very common for the first week after the procedure, which is why most patients don't feel completely normal. This is an inflammatory process that's incited by the procedure. Just the body's normal response or natural response to cutting off the blood supply to the fibroids, or really with any other tissue, we see the same. And some of the most common symptoms, and not everybody has them all, are the pelvic pain, which, as I mentioned, we can control usually very well with the pain medication regimen and the nerve block that we do. Many patients get a low-grade fever. They get an elevated white blood count. They have general malaise or fatigue and lower than normal energy levels. And nausea is very common for the first couple of days after the procedure, a little vaginal spotting or discharge. Constipation is usually a side effect of more the sedation or the medications that we use for pain control. But overall, most patients recover within about a week's time. Next slide, please. So what are the expectations after UFE? Well, what happens to the fibroids when we cut off their blood supply? Well, there are two physical changes that occur. The first thing that happens is that the average fibroid will reduce about 50% or about half in its volume. And while the volume or the size of the fibroid is very important, the other equally important component is the change in the composition of the fibroid. So as we've already stated, fibroids are made of muscle. Muscle tissue is a very heavy, very hard, very dense tissue. But not only does the fibroid decrease in size when we shut off its blood supply, but it also changes from that heavy, hard, dense muscle tissue to a much lighter, kind of softer, spongy, scar-like tissue. And it's the combination of these two changes that lead to symptom improvement in the majority of patients. The bleeding symptoms, like the heavy menses, usually respond first. Usually the first cycle or two after the procedure, patients notice a significant difference. The bulk symptoms like the urinary symptoms, pelvic pain, pressure, constipation, those kind of symptoms tend to take a little longer, maybe a couple of months, and then all the symptoms should continue to improve slowly over the course of several months. The majority of the changes in the fibroid occur in the first 6 months, but the fibroids have been shown to be able to continue to shrink and change even up to a year after the procedure. But overall, the UFE procedure is almost 95% effective for controlling bleeding symptoms and about 90% successful for control of the bulk symptoms. And it has a very high patient satisfaction rate of between 85 and 90%. Next slide, please. So we do 3 routine follow-ups after the UFE procedure. We work very closely with many gynecologists all over the really Houston and Southeast Texas area. And it's important, in my opinion, to be under the care of both at the same time because we both offer different things. And together, I feel like we can care for patients the best together. But we do 3 routine follow-ups in our office after the procedure, one at a week, one at a month, and one at 4 months. These can be done virtually as long as there are no unusual symptoms or issues going on. We'll see patients virtually. But if they're having unusual symptoms, which is fairly uncommon, we insist on seeing them in person. Of course, we'll see patients at any other time there are questions or concerns. And then in regards to repeat imaging with the MRI, we really only do it if around that 4-month period, patients are still having significant symptoms, and we'll repeat the imaging to see why. Otherwise, there's really no need to because as I tell patients all the time, we're treating you as the patient and your symptoms, we're not treating the pictures. But usually there's a strong correlation between the two. Next slide, please. So all procedures have potential risks and complications. So what kind of things can we see after UFE? Well, first of all these things are uncommon after UFE, but it can lead to an earlier than normal menopause for patients. It can cause what we call premature ovarian failure or premature menopause. That is an age-dependent risk factor. So the closer a patient gets to the average age of menopause, which is, early 50s, the more likely it is to occur. For patients less than 40 years, it's very uncommon, less than 1%. Between 40 and 45, it's usually like 2 to 4% risk, and then greater than 45, it can jump up to 2 to 5 or even up to 10% if a patient's very close to the average age in the early 50s. Infection after the procedure is very rare, but it can happen. Infection inside one of the degenerating fibroids or the uterus itself, it's a less than 1% risk. We do give all patients antibiotics before and after the procedure to help minimize that risk. Anytime we put a tube inside a blood vessel, there's a theoretical risk of bleeding or damage to the vessel, but everything's done under imaging guidance. So everything is done under direct visualization and nothing is done blindly. So that personally has never happened to me, knock on wood. I'm not planning to start that anytime in the near future, but it is always in risk. Patients can develop chronic vaginal discharge. Usually a discharge for a week or 2 after the procedure is very common. It can go on indefinitely. Usually that's related to what we call a fibroid fistula or a communication between the generated fibroid and the endometrial cavity, but also quite uncommon. And then some patients are allergic to the iodinated contrast that we use during the procedure to find our way through your blood vessels. It's the same type of contrast that's used for a CT or CAT scan, but like all contrast media or like all medications, a small percentage of patients have an allergy, but they're all treatable, and we have everything needed to treat them, and they happen immediately. Next slide, please. It's a very common question. What are the chances of getting pregnant after UFE procedure? Well, there's some things that we do and we don't know about future fertility and pregnancy after UFE. We do know it's very possible to get pregnant, have a normal pregnancy in a normal child. It's been reported hundreds of times in the medical literature. I've had it happen in many of my patients over the years, but there are also some unknowns. So what we don't know is whether there's any increased risks. So increased risks of infertility and increased risks of complications of the pregnancy should one become pregnant. No one's ever shown that there are, but no one's ever shown that there are not. And really the whole concern centers around the blood flow to the fibroid that's left after UFE, or not to the fibroid, to the uterus after the UFE, and whether it is, robust enough to support the pregnancy or not. But, what I like to say is, there are risks with everything. So with myomectomy and UFE, both preserve the possibility of fertility, but unfortunately neither one guarantees it. And it's really a case-by-case basis on which is the best option in patients that desire future fertility or pregnancy based on the size, number, location of the fibroids and the patient's overall desires, as we've discussed. Next slide, please. I've touched briefly on the adenomyosis, which is a very common, more common than we ever anticipated. Basically an endometriosis of the muscular wall of the uterus that can cause heavy bleeding and bulk symptoms and other debilitating symptoms identical to fibroids. When it occurs with fibroids, it can be difficult, if not impossible, to tell what symptoms are, how much of the symptoms are being caused by one versus the other. And quite honestly, most of the time it's both. But it doesn't prevent a patient from being a candidate for UFE. It does change our overall approach a little bit, and it changes the outcomes a little bit. So whenever adenomyosis is suspected and we're going to do an embolization procedure, we use one size smaller particles. Same particles I just showed you, we just go down one size. That's been shown to work better for the adenomyosis. But even doing that, we know it doesn't work quite as well for adenomyosis as it does for fibroids only. So for fibroids only, as I showed you, we're like 90% plus effective in controlling symptoms. With adenomyosis, it drops down to like 75%. So there's a higher risk of persistent or recurrent symptoms anytime adenomyosis is present following an embolization procedure. Unfortunately, the only definitive therapy for adenomyosis, because it can't be removed like fibroids can individually, it's more of a diffuse process. So the only definitive therapy, the only thing that we know of that works 100% of the time is a hysterectomy. Next slide, please. We can also do preoperative embolization in patients that have very large fibroids. Fibroids tend to be very vascular, so the blood loss at the time of a myomectomy can be significant. And so we can reduce that blood loss by taking the blood supply away from the fibroids. We can also attempt to change the surgical approach. So if a patient's on the borderline as to whether the surgery has to be done open or can be done through one of the less invasive means that Dr. Mott explained, by shrinking the fibroids in the uterus after the embolization, we can make the chances of having that less invasive surgery more possible or more likely, and reduce the risk of blood loss at the time as well. Usually wait about 3 to 5 days between the embolization and the surgery if the main goal is blood loss reduction, and 3 to 5 months, or really I say, as close to 6 months as possible for debulking or minimizing the size. Next slide, please. So what can you expect from us? I mean, really, I started this practice with the intent of really trying to make a difference. I feel like our system in so many ways is broken, and it's not physicians' faults, but there's so many that just don't spend the type of time I feel like that patients deserve at times. And so we try to provide a different experience of kind of a concierge level care. And it's one of the things I love about my current practice and situation is that I have the time to do it. When I was in the hospital, I did not have that kind of time. But I feel like in many ways, patients deserve more. And we're all about education, talking about things we don't do in addition to the things that we do, and really trying to provide a bigger picture for patients. Our primary goal or expectation when we do a procedure is safety. Safety always comes first. If I don't think it's safe, I'm not going to do it. And it's by picking the right patients for the procedure. Because like I said, my procedure is not best for everybody. We also offer a lot of flexibility. We have multiple office locations. We do a lot of telehealth visits, so we give patients a lot of different options. I communicate and work very closely with Dr. Mott and many other gynecologists around the Houston area. I think communication is key. That's the other place I think a lot of physicians fall short, is in communication, because when physicians communicate, I feel like patients are cared for in a better way. We do routine follow-up, and I'm always accessible to patients. I mean, every patient gets my direct phone number. If they have any issues or questions, they can always call. And then most of all, we expect excellent outcomes, because if we do everything above, it leads to that. So next slide, please. With that, I appreciate the opportunity and the time. And I guess we can open it up to questions, but thank you very much.
Yeah, thank you so much, Dr. Fischer and Dr. Mott, for those wonderful presentations and great information. Does anybody have any questions? If you feel comfortable enough to unmute yourself, go ahead and do that. And if not, go ahead and type it in the chat. But while we wait for those questions to come up, I have a few questions. But I guess my main question is, what's the biggest takeaway that we should take from today's presentation? If there is anything you can let us know about fibroids that we should remember, what should it be?
Dr. Mott, you can start.
Okay, no problem. Well, would it be? That, all menstrual cycles are not the same, that a normal blood flow from a menstrual cycle is a quarter of a cup of blood. If you're having more than that, then you need to see your provider. Menstrual cycles should not slow you down as far as your activities. It shouldn't be anything that you have to go home from. It shouldn't be anything that you can't plan your regular activities around without any difficulty. If you're having those kinds of problems, then you need to seek your provider. And certainly there are multiple different options on treatments for difficulties associated with menstrual cycles. And fibroids are one of the things that can cause menstrual cycle difficulty.
And I would say that it's really imperative upon patients to educate themselves through a variety of different means as best they can as to what the different options are out there. Because unfortunately, there's still a number of providers that really only talk about the things that they do. I feel like it's important to educate patients and for patients to really take that responsibility on themselves to know what all is out there so that you can make the best decision for yourself, regardless of what that is.
Okay, great. Thank you. We have a question in the chat. What resources are there available for uninsured or underinsured women?
For providers to see a provider, certainly Harris County has multiple, okay, facilities that are available throughout the county for those that are underinsured or uninsured. And certainly they can have annual visits as well as assessments for problems, and they can schedule those appointments. As far as treatment modes that are available, there are providers that are assigned to each one of those areas throughout the community. And certainly they are available and willing to answer questions and certainly get ultrasounds, MRIs, those types of things can be done through the Harris County. Okay. And that will allow them the assessment of what is going on with their cycles and their bleeding.
Okay.
Yeah, I would agree with that. And there are people in the Harris County district that are doing the UFE procedure too.
Okay. Thank you. Another question to wrap up the presentation. If a family member has had fibroids, is it something that can be hereditary?
One of the things I talked about in the discussion is that many times you will see other women in your family that they may not know that they have fibroids, but they know that everybody's period's been horrible. Okay. They last a long time. They're incapacitated by it. They have to change their schedule from it. And that some of the ladies may have had a hysterectomy because of problems that they had with their cycle. So, I think any type of illness across the board needs to be shared with other family members. Okay. Especially those that can be hereditary. And we're not talking just about uterus, but breast and multiple things. And we oftentimes in families don't give that information. There is nothing that you have done or anyone who has fibroids has done to make this happen. So it's not anything that is a reflection of you, but it is something that's happening in your system, and that information needs to be shared. But there are lots of different options, okay, as far as modes of treatment and things that people need to know about, and they can't know it, okay, if the only way they're going to get it is they have to have been to a provider. Some people never get to a provider, but if they have family members that have, then that information can be shared, and that can help them, okay, to maintain good health.
Yeah, I'd like to add, I think, I get asked this question all the time, like what leads to fibroids? And I tell patients that if I had that definitive answer, I might win a Nobel Prize. So,
Really.
but, I think there's much more to it than we know. I think we're just scratching the surface, really. I mean, Dr. Mott mentioned the vitamin D deficiency. I mean, there's been other, people that have tried to link it to dietary and environmental factors. I actually believe strongly that there is something there, but we just haven't really gotten to the bottom of it yet. But the one thing that we do know for sure is that there's a very strong genetic component.
I have
Okay.
one last question, and it looks like we also have one in chat. Is it a mutation gene? Are they dormant or triggered by any form? And then lastly, is there any kind of lifestyle changes that we can do to prevent fibroids or the growth?
I think there's a lot of gene therapy that's available, but there is no mutation that we're aware of, okay, as of yet. We are doing, and certainly there are a lot of genetic processes that are going on related to genetic forms of cancer and identifying those genes. Most of the attention is being focused on them so that we can develop what is hereditary for breast, for uterine, for ovarian, for pancreatic, for colon, for multiple prostate, multiple forms of cancer. And certainly genes have been identified for those forms of cancer. And certainly localizing those people and making people aware of that allows them to prevent the development of cancer. As far as things that we can do, okay, to help with that, I think that, certainly as we continue the medical research, et cetera, associated with it, then we'll get more information. Things that you can do yourself. Certainly, we talked about obesity, being at your normal weight. Certainly, seeing your provider on a regular basis. I know there's been a lot of confusion on whether or not you need to see your gynecological provider on an annual basis because of the variance in the pap smears. Pap smears can be done 2 to 3 years apart, but your annual visit should be done annually. There is no change in that. A pap smear is simply a cervical smear for a cervical cancer, and that can be relegated based on your history and whether or not you've had any HPV exposure, but it does not keep you from having your annual exam. And I think there's been some confusion in the community as to, well, I only need to go every 3 to 5 years. No one said that. Okay. And certainly that is not what your provider would recommend.
Yeah, I don't have much to add to that. I think that's great information.
Wonderful.
All right. Thank you so much for doing this. We really truly appreciate taking your time out of your busy day to come and inform us about this amazing topic that we don't always get to hear about. But before we wrap up, I am going to pass it on to our program coordinator, Kenya Furman, which is going to share a little bit about a future event for those of you all who are tuned in. But besides that, that is all that we have for you all. Thank you all so much for being here and enjoy a wonderful, beautiful weekend. Kenya?
Thank you, Dr. Mott, and thank you, Dr. Fisher. Yes, just to wrap it up, I would like to inform
Ma'am, what can I
everyone
do for you?
who chimed in
Hello?
into the presentation. We have an upcoming Doc Talk. It's a free
Hello? May I help you?
educational. There, give me 1 second. It's a free educational event open to the public. It will be taking place on August 28th at the Health Museum. The topic would be about heavy menstrual bleeding, where facts and fallacies will be discussed, which is a good additional add-on to today's topic. So if anyone's interested in joining, I'll be putting the link in the chat. Feel free to join and register. Like I said, it's a free health education session. Free lunch is also provided, and you get entry to the Health Museum. Thank you so much.